sir.
All right, ladies and gentlemen, welcome to another episode of the Healthcare Growth Cycle Podcast. We're super happy to have Muhammad on. We connected, what was that, Muhammad, maybe 2 months ago? And there's a lot of overlap in the home care industry. And ironically, a recording I just did on Friday actually was with another fellow home care AI consultant, which I could probably talk to you more about that conversation after this podcast, Muhammad. But, there's a lot of buzz in the industry. It's a great place to be. I'm more on the durable medical equipment side. And so the overlap isn't like 100%, but there's definitely things that tie into each other. So it's just really, really great to have you on the show and to get your insight as a home care founder and CEO in the healthcare space. And happy to have you here.
Yeah, no, Christian, thank you so much. It's a pleasure, man. I know we connected, about 2 months ago, and I feel like time just flew by.
Yeah.
Yeah, and here we are. I don't know if I was ready for this, but I guess it's never a perfect time. So I'm glad we're able to connect today and have this discussion and conversation. To your point, I mean, home health, which side is I'm on now, but home health, home care, I mean, definitely a lot of opportunity. And as you mentioned, I think AI has a big role here, especially with a lot of the issues and challenges that the home health industry is currently experiencing around staffing shortages. So, I think it's about leveraging the technology with the existing pool of caregivers that you have, whether you're on the skilled home health side or you're on the non-skilled side. In both part of the business right now, there's just a heavy regulations, documentation requirements, and I think AI has a big role to play in that.
Awesome. Yeah, and I can't wait to get more into that. Just to start, I think just kind of giving an intro about yourself, if you'd like, would be really, really helpful for the listeners. Maybe starting with some of your background, how you got into healthcare to begin with, and then how you ended up founding ChoiceCare. I think that'd be really, really helpful.
Oh, yeah, absolutely. So, you know, it's just very early when I was in college as an undergrad. I went to Washington State University in Pullman, Washington, on the West Coast. I always knew I wanted to go into healthcare. I wasn't sure exactly what I wanted to do in healthcare initially. And right around the time when I had finished my undergrad, I did my undergrad in sociology. And once I finished undergrad, I'm like, okay, what do I do with the degree in sociology? I know I wanted to be in healthcare, so naturally, I started a initial kind of a part-time job in the Seattle area working for a nonprofit. And they were at that time transitioning into from paper charts to electronic.
Wow.
And that's going back to, I'm kind of dating myself, but this is back in 2007, 2008. During that time, what I realized was that, okay, healthcare is about to go through some initial transformation, and there's an opportunity here where I should probably look at getting into something very specific. So I ended up going to University of Washington in Seattle. In the evening, they had a post-BA certification program in health informatics and health information management, which essentially allowed you to sit for a national board exam, which is the RHIA, which is a Registered Health Information Administrator exam. And ended up, finishing the program. I was still working for this nonprofit in Seattle, helping with their transition from paper to electronic. They were a mental health type of an organization. So there was a lot of HIPAA, patient privacy, security, a lot of paper charts. So as I was finishing the program, I ended up staying there and helping manage and oversee their EMR, essentially project and helping with the HIM department, moving them from paper to an electronic system. So that was, kind of the beginning of the journey. And then along the way, that was kind of a niche that I found. I became a HIM specialist, working with after that several organizations, helping them transition from paper to electronic
Wow.
EMR system. Implemented next gen for a large FQHC in Southern Illinois. After leaving Seattle, that was kind of my first big quote unquote opening. From there, I went into another organization. They were again in a similar transition. This is around 2010, 2011. The High Tech Act was passed. President Obama, essentially was in office, and he was looking for all healthcare organizations to move to EMR systems. So this is around the meaningful use era. Those of us that have been around for a while in healthcare, where essentially provider groups were being incentivized to move from paper to electronic, and they were receiving, it was a nice amount of payment every year, depending on the size of your organization. You were receiving anywhere from 10 to 15,000 per provider per year during this transition time to help with alleviate the cost of the transition, right?
Sure.
Uh, so, in Chicago, I worked for an organization called Friend Health, helped them transition into an EMR system, which was GE product at the time. General Electric, believe it or not, was in the EMR business as well.
Wow. Wow.
They eventually ended up selling that to Athena Health.
Okay.
While I was still there, but GE was in the EMR business, and we had Centricity product that we essentially implemented into the health center and took them from paper to electronic again.
Wow.
Uh, Served about, I think, at the time I started there, we were close to 15 to 20,000 patient lives that we touched. It was a federally qualified health center. And in that federally qualified health center environment, we were part of a HCN, a health center network in Chicago, which made up of, a lot of different smaller to large size community health centers that came together. And essentially, it was kind of a group pricing model. And they were able to purchase the Centricity product in a more efficient way, and then they didn't have to build out their own EMR teams center level. So
Mhm.
that at the health center network level, they controlled a lot of the network. So while there, I think opportunity came within the organization. Moving from HIM, I moved into healthcare operations as
Wow.
a director of patient service, and consolidated multiple roles into one. So that was, kind of my first opportunity as a director leading a large system.
Yeah.
And we were working pretty closely with a lot of the community health centers, City of Chicago. University of Chicago was our kind of the main hospital system that we were quote unquote under the umbrella of.
Yeah.
So we had residency programs. I oversaw patient scheduling, contact center, referral management, health information management,
Wow.
and really became kind of a full circled operator in the healthcare space
Yeah.
during that tenure.
During all of that transition from paper to digital, did you experience a lot of internal resistance in these organizations? Was there a lot of skepticism to go digital in the healthcare space at the time?
Yeah, I mean, I think, Christian, naturally you had providers who had been used to the paper,
Yeah.
right? And um, But I think to a certain degree, a lot of people, although they were skeptical, but they were also excited
Okay.
because, those of us who worked in the paper world initially, sometimes it's one paper chart, but patient has multiple disciplines that are trying to take care of the patients. And depending on who's seeing the patient, that paper chart is sitting on a doctor's desk or a nurse triage, and it just made coordination of care very difficult and challenging, right? But I think definitely there were folks that retired, providers who were older, during that time. Didn't feel like that this transition they wanted to be part of.
Yeah.
And in general, but a lot of what I think helped was just, leading change management, in leadership. That was
Yeah.
critical.
And did you
Bringing
do
people
more?
along.
Yeah. Did you do more of that change management once you got into that operations role, would you say? Or what were you doing? Because you were kind of like an EHR architect almost, no? Like when you first started in this?
Right.
Yeah. So did you get more, yeah, I guess just working with providers and other stakeholders to help with adoption as an
But
operations
yeah, so
leader?
right. So I think having that background has really been integral to my success in healthcare
Sure.
operations. Because as an operator, if I didn't have that background, a lot of time it's hard to make the connections on how the back end of various systems and processes are working. So I think as a leader, once I was in a operational role, I was able to connect those dots for our provider groups that I was working with, whether it was with our partners at the University of Chicago or the City of Chicago. Um, but it was essentially setting up the infrastructure, right? And a lot of the legwork went into setting up EMR workflows, electronic fax systems, digital signature and capture process and systems that were needed to modernize the workflows and processes in FQHC, which are, federally qualified health centers are severely underfunded, and that program really allowed a lot of the FQHC to offset the cost,
Okay.
right? So in terms of, I think working there, that was kind of the defining part of my healthcare journey in the federally qualified health center, because I really was able to own the front and the back end of the operations to integrate workflows and optimize systems and processes and lead the change management growth of the organizations. By the time we left, I think we were close to 40,000 patient lives,
Wow.
uh, nine primary care and 14 behavioral health sites with the sister organization that we ended up acquiring. That was on the behavioral health side. We were implementing integrated behavioral health
Wow.
into our primary care spaces. And we were also integrating primary care into a lot of the behavioral health clinics that we acquired as part of the transition when we acquired a new organization here on the south side of Chicago.
Yeah.
Um, while there, I started. Then I went to UY Urbana Champaign in 2020. Literally right before COVID hit, I started my MBA, and that year, I think everything just changed. Now, one of the things I like to tell folks is that the federally qualified health center, they're actually in a really good position when COVID did hit. And I lived through it and missed of it because we already had partnerships with various hospitals and systems. So we were working closely with initially setting up testing sites. We had one of the first City of Chicago and University of Chicago a managed site that we essentially staffed, where it was a drive-through COVID testing location on the south side of Chicago in severely, again, underserved communities, where we redesigned the parking lot as a drive-through COVID testing mechanism for our patients so they didn't have to come in. And as I mentioned, the earlier investment that we had made into the EMR system with electronic and digital workflows came handy because everything, as you remember, nobody wanted to touch anything. So we had QR codes that would go to the patient's phone. They would come in and check in and sign in. So all of those things, cumulatively were part of my journey as a healthcare leader. And then I transitioned around 2021. I transitioned to a senior-based care, and that was the beginning of I think me trying to see, okay, where do I want to go from here as a healthcare leader in this space. Um, and I was there for about 2 years, leading a center on the south side of Chicago, working for a large internet national entity GenCare Senior Medical Center,
Okay.
ChenMed, and really focused on reducing the cost of care and value-based care model there.
Wow.
Um, and so ultimately ended up in a private equity environment, which is a small group based out of North Carolina, and saw that they were focusing on home health. And from there, I started looking at building my own team, found some investors, and we started ChoiceCare Home Health. And
Wow.
we acquired actually an existing license because in home health space, it's highly regulated, and to start fresh and new, it takes months on and a year or two to get your credentialing and licensing and everything in place so you can actually see patients and have reimbursements.
Yeah. Yeah.
So,
Wow.
so we were able to acquire an active license, and then we're building based on that today. And I'm one of the operating partners and the president and CEO for ChoiceCare Home Health. And all of those things that happened kind of brought me here today to focus on where I think the healthcare is shifting, which is virtual and at home.
Yeah. What's the biggest marker for growth in a home health organization? Is it the number of patients served? Is it revenue? Is it a combination of both based on margin? I've actually never even thought to ask that, which maybe is kind of
Yeah.
crazy, but I'm just kind of thinking about this right now. And you had been
Yeah.
focusing at the behavioral health clinic that you worked at patient growth. I'm just curious if you have
Right.
reasons for using one metric for growth over another when you're presenting to a PE board or someone else, investors.
Right. Yeah. So, I think in home health, I mean, it's really your biggest measurement of growth is how many active patients do you have under census. Okay. That means they've been admitted, they're actively being served by your agency. And then I think from revenue standpoint, obviously that's the next big metric, which is what is your payer mix? Do you have enough of a payer mix between various type of pairs, and are you credentialed, or do you have in network with the pair types to be able to sustain your business and operations? Right now where we're at today, I mean, home health is it's going through a very challenging payer environment when it comes to skilled home health, and part of that has to do with really the influx of the Medicare Advantage plans. The Medicare Advantage plans are not paying the provider groups in the manner that's operationally sustainable in the long run, uh, versus traditional Medicare. So, typically or traditionally, I would say that in home health, skilled home health, the majority of the patients were traditional Medicare. So let's say maybe 10 years ago, the census makeup was about 70-30, or even maybe less, 70-20, 80-20. Uh, Medicare, and maybe 20% was the Medicare Advantage plans,
Hmm.
right? But as more and more payers got awarded with Medicare Advantage contracts through CMS, really, I think the idea was to reduce the overall cost of care. But what it's leading to is, from what we're seeing from home health perspective, it's leading to a very challenging reimbursement environment. I mean, you have large healthcare systems that I was recently at a conference here in Illinois that I was speaking to that are operating on negative margins on the home health side, because now what has happened is their census has shifted. Now it's 70 or 80% Medicare Advantage and 20% or 30% traditional Medicare.
Okay.
And that shift it has put a lot of the agencies underwater
Wow.
on the home health side, and it's making it challenging for them to continue to offer service, at the level that they need to, and at the level the patients really need.
Yeah. Is there a shift to private pay at all with those organizations that are on Medicare Advantage or
Well, yeah, I mean, so again, it depends on you as a what level provider you are.
okay.
If you are there's obviously a private pay market in this space now, a big one. because there's a lot of families who also, if they're able to afford and they can pay for it, because when Medicare Advantage plans aren't paying for the care
Yeah.
beyond a certain point, right? So there's prior authorizations, as everybody's heard, with the recent news from United and some of the other payers, where they're limiting access to care by introducing prior authorizations, right? The prior authorizations is one way they're limiting how much and how long a patient or somebody can get access to care, right? Um, so that's having an effect as well. So private pay market is there, but again, that's not accessible to everybody because the overall cost of labor has gone up, right? I mean, as we look around us, everything has gone up. And then the second part of the problem is that a lot of the payers, they're not paying the rate to agencies that's going to allow them to more than just survive, right?
Wow.
Because end of the day, it is a healthcare business, and you do have a cost, right? So on the home health side, there's a lot of pressure points on agencies, large or small, right? And some of the executives that I recently spoke to at the Illinois Home Health and Home Care and Hospice conference that was here in Chicagoland, they're incorporating additional service line like hospice, for
Okay.
example, because hospice benefits are still under traditional Medicare. So they're using hospice as a way to offset the losses they're having on the home health side,
Wow.
right? So as an organization, if you're not diversifying your business lines, and that's one of the things we at ChoiceCare Home Health is now evaluating.
Okay.
Basically, we're looking to see if, how are we going to continue to provide the services to our patients. So as a leader within the organization, I'm evaluating various service line that includes non-skilled home care side, and then also include the hospice, and then the private duty side as well, because you have to have those different buckets of revenue to sustain yourself as a business, because home health by itself is no longer um, in a place where you can sustain your operations and your business if you don't diversify it.
Yeah. Absolutely. Was gonna say something on Medicare. It just escaped my mind. Oh yeah, so with the constraints on Medicare Advantage and providers and insurance companies not paying the sufficient amount, is that what's then driving up staffing shortages within home care?
Yeah, I mean, I think this the staffing shortage in healthcare. I mean, this is a chronic issue.
Sure.
This is more of, I think, we have the baby boomers and the current people in the workforce that are retiring, or they're just leaving, right? And altogether, because of how burnout folks are. As you hear study after study, you look at news reports after news report, you have
Yeah.
nurses, providers, they're all kind of leaving the healthcare realm because it's taxing,
Yeah.
right? Especially in home health, the staffing challenges are even worse because you're getting in your car, you're driving to the patient home. There's wear and tear on that. There's transportation pressures. Now with the high cost of gas, that any inflationary points have a direct effect. And we're not a type of a business that you can just raise salaries, because you're dependent on payers, especially if you're a Medicare certified entity, and they're not factoring in that, oh, well, everything is going up, therefore we should increase the rates automatically. It's a renegotiating mechanism. And if you don't have the numbers and you're not a big enough player, sometimes it's like, this is what we're going to give you, take it or leave it,
Yeah.
right? Able to have any leverage in even negotiating the rates to a point that's needed to sustain the business.
Wow.
Um, so the staffing shortages, it's just generally speaking, we just have a aging population. A lot of the baby boomers are retiring. A lot of the new grads that are coming into the workspace, again, home health, it's different. You don't have the safety net of having a team behind you, because you're literally on the road and seeing patients, quote unquote, you're on an island. I mean, we have systems and processes set up to support the in-field caregivers, but there's been challenging just in fulfilling those roles because a lot of people just want to be in a facility-based environment and not have to drive around, not have to spend hours on the road,
Yeah.
and versus being patient care.
Yeah. Wow. Shifting gears a little bit, focusing more on the growth of your home care company as well as using I would just like to touch on some topics there. First, building your team. What has that journey been like actually founding ChoiceCare and building a team around you as a CEO?
Yeah, I mean that's as a CEO of a company, that's pretty much your number one priority, right? Because there's so much that gets thrown at you throughout the day. So for Choice Care, again, when we acquired the license, we had some staff that was still actively working for the organization, and that we retained. But naturally, there were folks that, like I mentioned, they were at the end of their career, so they were looking to exit. So really, I had to look at what were the current systems and processes? How do I build a team that's both flexible, but at the same time, it's also being able to meet the demands of the current time and place we're in. So, I leveraged technology a lot. So, one of the first thing I did was within the home health agency that we got the license for, in their current infrastructure, I mean, they were still using a paper fax. Everything that was coming in, healthcare is one of the only places where fax is still pretty much the
Right.
primary mode of communication between the various groups, right? So we decided to incorporate a Ring Central and moved all of our communication virtually. And then we added virtual positions across various time zones, including leveraging offshore support to help in off hours to around customer service roles, right, where we could use their help to support the intake process of the team, building that communication loop. Um, we integrated Microsoft Teams into
Yep.
our platform. So, at this point, I think where we're at now, a lot of companies that are already existing in this space, especially around the EMR side, they're now feverishly trying to incorporate AI into their products that are already existing. And to me, that's what needs to happen with the current platforms, because right now we have too many independent products that's out in the market, and not everything and everyone is being able to speak or talk to each other,
Yeah.
right? You have companies like Access, Kinzer, Sky, Alora. They're all looking to build AI features into their existing platforms, and they're trying to integrate with various digital referral networks so you can communicate and talk to referral providers through that channel. So, I mean, the building the team has been, it's been challenging from staffing standpoint, clinical staffing. That's where it's been the biggest challenge.
Yeah.
Still, it's an ongoing. We're looking at various way to partner with the new grads programs, but in home health, usually we try to find more tenured staff because, again, you are out in the field on your own when it's clinically. But I think one thing that has allowed me to really leverage is my virtual uh, office setup, which allows my team to be available, especially for the intake, being able to answer calls, being able to integrate with electronic fax systems, and not physically be tied to an office. That has helped quite a bit.
That's great. Yeah. Any like major challenges with growing a team that you want to talk about here, like, or tips or advice for a CEO in your position when scaling and leading?
Yeah, I mean, I think it's a balancing act, right? So when you are trying to scale, grow, and build, the the best analogy is it's like you're building a plane as you're flying it, right?
Yep.
I'm sure you've heard that before. So from my perspective, the way I'm approaching this is that um, where is the immediate need to either fix? Is it around patient care, right? Because end of the day, that's the driver of our business. Is can we get timely care to the patients when they need it? Do we have the staff to meet those demands that we're getting from our referral partners, whether it's coming from the hospitals or it's coming from primary care group? So focusing really there, and then do I have enough support on the back end that's focused on the customer service aspect of communication. Communication is key. So ensuring that the team is on one platform, because in home health, you're piecing together a lot of different aspects of the care through full-time employees to contract staffing to staffing companies. So, a lot of time you're working in 3, 4 different systems. So bringing everything and all the information back into one place. So for me as a leader, I had to set certain dashboards
Okay.
from
Yeah.
yeah. So how do I measure success of the business? Do we have enough growth happening? So do we have enough referrals coming into the pipeline? And then helping my team with some of that growth where working with my marketing folks on the ground, going out in the field, teaching them how to interface with various referral sources. Then operationally, working with my virtual teams so they are communicating well together, right? We instituted a daily huddle when we saw, okay, there's a breakdown in communication because when you're virtual, the assumption is you can reach out and get to everybody and get what you need. But what ends up happening is because it's not like you can go around the cubicle and ask a question. Sometimes people just are hesitant to have that conversation. So we now have a daily huddle where the leadership with the operation teams has a daily morning check-in. And during that time, you can address your bottlenecks, your issues, challenges that happened
Yeah.
yesterday. And then we have dashboards that we're tracking for number of cases we have, number of patients we need to discharge, the QA dashboard. In home health, the documentation is the biggest component to your success,
Sure.
especially now in the managed care side. Prior authorizations are huge. We have built a billing team, a prior authorization team, and they're all now in sync in one platform where they're communicating and talking. So before we even accept a patient, do we have the approval from the payer to go ahead and go see that patient, right?
Got it.
Sometimes if you're not doing that, you're then at the back end, your AR account receivable revenue cycle side just grows and balloons. And
Yeah.
if you can't collect, you can't sustain operations.
Ugh.
And if you don't have prior authorization in place, you can't bill.
Yeah.
So those are things that we as a organization have gotten really good
This is
at,
great. Yeah.
uh, and that has really allowed us to keep our AR uh, to within the last, we're usually within 30 to
Yeah.
45 days of the last patient visit, and we've been able to build them episodically or
Wow.
within their 30-day episode time frame.
What would you say is the key ingredient for the centralization of those sources being a success to let those dashboards show you the accurate metrics? Is it standardizing the workflows in the EHR and then you're connecting to the EHR's database essentially? Is that what's happening? I'm just curious, being a data
Yeah, I
person.
mean, so right. I mean, so the biggest I think is it's your intake process. The starting point for any organization, whether you're in the home health side, even when I was at a large community health center or the senior care primary care group, it's your first point of contact with the patient and whoever that referral is sending to you. Because if you're not getting the accurate information on the front end, because remember, billing is the last thing that happens. Okay. So what I had to really do was to understand was from a workflow standpoint, how are we intaking the patient in home health? Because if a referral source is sending us a referral and they're not sending us the accurate insurance information, and we accept a case and we go out and provide the service, we're taking a risk on, are we going to get paid from the payer later on? So that's the first part that we control very much on a daily basis. We need to have accurate information. Then standardizing workflows around that, making sure that everybody is on the same page. And then in terms of operationally, then we had to operationalize certain dashboards that we're looking at daily, certain things we're looking at weekly,
Wow.
and then we're accumulating the data and looking at it monthly and then quarterly.
Yeah.
How are we trending, right? Because in home health, again, your business operations can suffer if you're not looking at this data and you think, oh, I'm going to go ahead and look at it in 90 days. Well, in 90 days, you may not have enough cash flow in the pipeline to operate as a business, because if you didn't do what needs to happen today, you're not going to be able to bill in 30 days, because in home health, quote unquote, it's not a daily billing like regular provider group or regular facility process. You can bill for an episode, 30-day episode,
Wow.
a minimum. So you have to have a patient with you, and then at the 30-day mark, after their visits are complete, and then you have documentation requirement. Did the doctor's orders get signed? Did the plan of care get signed? If none of those things are being monitored on a regular basis, then at the end of the month, you're now hitting a 30-day mark where you're either out of compliance, you don't have enough revenue ready to be billed, and then with payers, it's at least 30 to 40 days, right? So there's so many
So many moving
intricate
parts.
steps.
Yeah. That's
So,
crazy. Yeah.
so it's not just a simple, you get the patient, you see the patient, and you get paid.
Yeah.
I think Mark Cuban recently posted something around this, that in healthcare, most of the providers, that are accepting insurance plans, whether you're taking Medicare, Medicaid, Medicare Advantage, it doesn't matter. We're operating like the subprime lenders without any assets tied to it, right? We're seeing the patient, we're paying for the cost of seeing that patient up front, and then we are expecting to get paid somewhere in the next 30 to 60 days
Yeah.
after the patient has been seen,
Wow.
right? And on our end, we're doing everything we can to document, because unfortunately, there's been a lot of fraud and abuse in home health, in the DME space. There's a lot of bad apples that have made things bad for everyone else. People that are trying to do the right thing are also taking a hit, because now, from regulation standpoint, there's so much documentation requirements that has come into space that it's make it very challenging if you don't have all of your documentation in place before you can go ahead and bill.
Wow. Thanks for that perspective. And just the way you broke it down, I think is one of the most helpful and easy to follow ways, at least from my perspective. So that was the clarity you just provided is huge. And I think the listeners are going to get a lot out of this. We're at about time. I just always like to give the guest the floor. So where can people reach you if they want to reach out to you, Muhammad? What's the best place to do that? And then anything else you want to plug, I'll just give you the floor.
Yeah, I mean, again, so I'm on LinkedIn, Muhammad Nazir, last name Nazir. Through this process, one of the things that I realized was that, I have developed a unique kind of expertise within home health, around billing, around credentialing, and then also just leveraging the remote work environment. I ended up also actually starting another company about a year ago. It's called ledgerlogicbiz.com. And basically what we're doing there is now taking our expertise that we have built, and we're now offering those services to other home health agencies to help them really streamline their operations, because I walk into certain home health agencies, some people that I know in the space, and they're still operating out of a fax machine. They're still printing everything and then scanning stuff back into into the EMR, right? So I think LinkedIn, ledgerlogicbiz.com, ChoiceCare HH.com. So we're doing everything we can to get our name out there, and then also just to make sure that we're influencing home health and everything in a positive way, and do what we can to serve the patients.
Awesome. No, that's beautiful. Yeah, and I'll make sure to include all those links in the show notes for the listeners. But ladies and gentlemen, this is another episode of the Healthcare Growth Cycle Podcast. Thank you so much for tuning in, and we will see you on the next episode. Thank you.
Christian, thank you so much.